Ms. Marchibroda.
Thank you. Good morning, Chairman Baucus, Ranking Member Hatch, and members of the committee. Thank you for the opportunity to testify before you today. My name is Janet Marchibroda, and I serve as the Director of the Health Innovation Initiative at the Bipartisan Policy Center. Founded by former Senate Majority Leaders Baker, Daschle, Dole, and Mitchell, BPC is a nonprofit organization that drives principled solutions in a number of areas, including economic policy, energy, housing, immigration, and of course, health care. Our Health Innovation Initiative conducts a great deal of research and engages stakeholders in promoting improvements to health and healthcare through the use of innovation and health IT, and my testimony draws upon about 6 reports we've released over the last couple of years. First, health IT plays a significant role in improving the quality, cost effectiveness, and patient experience of care. Last year, we convened a task force led by former Senate Majority Leaders Tom Daschle and Bill Frist, pulled people together and asked the question, what are the attributes of high performance in healthcare, new models of care? Then we looked out into the field to look at what health IT capabilities are required and where are the gaps. And very quickly, I'll run through those in my few minutes today. First, EHRs are key, and we've seen adoption move to more than 40% among physicians and hospitals, but there still are gaps. Small physician practices lag behind, as do small and rural hospitals. Also, there are many providers, such as long-term care facilities and behavioral health care providers, who don't qualify for the incentives. The second, and probably the most important point in my testimony, in order to improve quality and reduce costs in healthcare, we need information to flow across the settings in which care and services are delivered. This is not only needed for care, but also to calculate performance measures and to lay the foundation for new delivery system and payment models. Unfortunately, only 30% of hospitals and 10% of ambulatory practices are participating in operational exchange efforts. In order to achieve information sharing, 2 things need to happen. First of all, those EHR systems need to be interoperable. And I'm pleased to say, as we move from stage 1 to stage 2, we've moved from a very small 5 data types being able to transition to fully 23. And so I think we're well positioned with stage 2 to move forward on interoperability. But second, providers need to be able to and willing to share information. And unfortunately, as you mentioned, Senator, the primary barrier to information sharing is the lack of a business case for such sharing, given our primarily volume-based payment system. If there's one message that I can leave with you today, we must prioritize electronic health information sharing, moving forward in terms of allocation of resources and focus of federal agencies as well as the industry. We need to merge both the healthcare conversation and the health IT conversation. So what is the government's role? First, don't delay the start of stage 2. Second, align expectations for information sharing with payment, both inside and outside of meaningful use. Lead by example. Expand efforts to enable sharing of Medicare data to support new models of care. Assure public-private sector development of a long-term strategy for data and sharing that meets all healthcare priorities, not just those of meaningful use, and address the patient matching issue. The third gap area is around effectively engaging patients. The world is changing since high tech was passed. 85% of Americans use the internet and 91% own a cell phone. And we use electronic tools for everything else in our country, but not so in healthcare. Fortunately, I see change coming. Stage 2 takes a giant step forward in enabling providers to engage with patients electronically. And I'll tell you, I've witnessed this firsthand. Just last month, my 16-year-old son had knee surgery, and we were up at Johns Hopkins in Baltimore. And for the first time, they just installed a system. We were able to see his test results online, review his prescribed medications, and even securely message with his physician on follow-up questions without having to drive from Virginia to Baltimore to do so. And it's not just institutions like Hopkins, but also our pediatrician's office, which is in Northern Virginia, pretty small, unaffiliated with any large healthcare system, had also installed within the last year both an EHR and a patient portal. So much progress is being made with stage 2. One final point as I move to close. Since high-tech was passed in 2009, we have seen tremendous change in the healthcare system, as well as the technology designed to support it. Health IT must evolve and change to support rapidly emerging changes in the healthcare system. So future stages of meaningful use should prioritize information sharing, number one, but also transition towards the achievement of outcomes, moving away from things that, such as features and functions, and that will offer flexibility as we move ahead. The federal government should also consider carefully, from a regulatory standpoint, the actions it takes as it relates to the development of a regulatory framework for health IT under FDASIA. We hope that it will be risk-based, flexible, and one which promotes, not stifles innovation, and we've done a lot of work in this area. In closing, health IT is the necessary and critical foundation for higher quality, more cost-effective, patient-centered care. We are at a critical juncture as we embark on the second stage of this journey, and we look forward to continuing to support your efforts as you consider policy in this area. Thank you for your leadership, and thank you for the opportunity to share my insights today.